This is a video of a phaco emulsification done in a myope and in a person suffering from albinism, as you can see from the light colored iris. The cataract, although it looks like a posterior nodal cataract, it's probably a posterior subcapsular cataract. However, while dealing with this cataract, one should always take the necessary cautions. So let's see how I went about this surgery. As I said, the patient is a high myope as well, as most of these patients are. I initially put my 2.2 millimeter incision and then go ahead and place two side ports as well. I then fill the chamber with HPMC, 2% HPMC that is, and with a bent 26 gauge needle as a cystitome, I go ahead and perform my rhexis. The cataract is not as soft as it looks, but it's not hard as well. I carefully, using the pupil as a guide, make my 5.5 rhexis. And now, since I have a doubt whether this is a posterior nodal cataract, I am only going to perform hydrodelineation. And there you see the golden ring reflex. I will go in the same area and keep doing very sending in few bursts of the BSS in the same area as the hydrodelineation ring to try and separate this nucleus. I am placing some sodium hyaluronate as well, and then with my easy Phaco 2.2 millimeter tip and with a sharp chopper. As I told you, this is not that soft a cataract, so it can be chopped. I initially clear up some free cortex over the nucleus and proceed to do the quick chop method. There you see the first chop. Once you get the chop, it makes things much simpler. And then the second chop, I normally make my 4 fragments, but this has come up towards the tip, so I just eat it up. As you can see, I am using pretty high parameters here, and since this being a 2.2 tip, you will see slight fluctuations in the anterior chamber, but that's not too troublesome. Moreover, this is a myope, so I haven't exactly placed the bottle at a very great height. As you can see, I'm pretty comfortable. And then, having taken off the entire nucleus, I come out. Probably should have put in some visco before coming out. I thought this would be stable, but that's just the sheet of epinucleus coming up. There's nothing to worry about. In most pathological myope cases, you are going to get this trampolining effect. Using my bimanual, I find it is pretty easy to remove the entire and this is not a posterior nodal cataract, so I'm not too worried. In fact, I'm so sure of it that I go ahead and clean the posterior capsule as well under my capsular polishing mode. Since it's a pathological myopia, I am trying my best to clean it as far as possible. As far as possible, I would want to avoid doing any further procedures like YAG or a further posterior polishing in such a case. I know the capsule is not going to give way, so I'm going ahead. Once done, I'm injecting HPMC within the antechamber, and with the tip of the cannula, I'm trying to clean the posterior capsule as well. This works exceptionally well in most of the time. Now I have to inject my IOL, I need to increase my incision to 2.8. And I have opted for a yellow lens in this case. Do not know whether it helps in any way. However, I have gone in. You can see the haptic through the iris. And sometimes this can be extremely confusing because you really do not know whether you're in the bag or not. And I'm literally physically checking whether whether the IOL is in the bag. Doing this with the help of a Sinskey hook. And now I go ahead and remove all the HPMC. This I do very, very meticulously. I have to remove everything. And finally, I am hydrating the wounds. You can see the pain that I am taking to hydrate the wounds, making sure the chamber is completely sealed. Thank you for your patient watching.